Hello everyone, my name is Dr. Rahaf Kibrit. I'm a critical care clinical pharmacist based in Lebanon. Today, I will be standing on the negative team or the opposing group, talking about a very important topic, which is should African nations implement national genetic screening programs for early detection of prostate cancer in high-risk groups? What do you think? Let us see. So as we all know, prostate cancer is the second most frequent cancer and the fifth leading cause of death in males, with higher incidence in more industrialized countries, in Southern Africa, and the Caribbean. Why is that? There are several causes for the variation in mortality. First of all, we have the genetic risk and we have the role of the environment. Actually, there is an evidence demonstrating that significant differences in mortality rates depends on the ancestry. They found that the African Caribbean population has the highest rates in the world, 26.3 per 100,000, whereas the men of the Asian origin has the lowest, which is 2.5 per 100,000. According to the Genome-Wide Association studies, they have identified over 170 common risk alleles for prostate cancer, including the susceptibility region on chromosome 8q24. This region harbors multiple variants that have suggested to contribute to the ethnic differences in the prostate cancer. Therefore, everyone should think that genetic screening is a must in the African group in order to detect the disease and treat it appropriately. So, according to the American Cancer Society, it recommends that high-risk men, principally men with one or more first-degree relatives with prostate cancer, should have the opportunity to discuss and reach an informed decision with their healthcare provider whether to start screening for the prostate cancer from the age of 45. As we said before, that the basis of men of African ancestry being at high risk for prostate cancer is fundamentally genetic. So, combining the available screening tools such as PSA testing with the genetic risk profiling should have potential to inform the decisions in men of African ancestry. So why not? Why not to adopt such an approach? What do you think? Let us see. First of all, we have insufficient data and research. There is a severe lack of genomic studies on prostate cancer within the African population, meaning that the genetic risk factors are poorly understood from the first place. Secondly, we have a weak health infrastructure and resources. Most African countries have underdeveloped healthcare system and a scarcity of reliable cancer registries, which are necessary for effective screening programs. For example, in the pre-war Sudan's healthcare system, encompassing the WHO system framework, which is service delivery, financing healthcare workforce, medical supplies, health information system, and governance, faced several challenges. An overwhelming 95.94% of the population had to pay out of the pocket for their healthcare services. Additionally, the country faced critical shortages in healthcare workforces, as in 2019, the density of the physicians, nurses, midwives, and other healthcare workers stood at 3.6, 14, 9.1 per 10,000 people, respectively, which is far below the WHO minimum threshold density of 22.8 health professionals. Also, we have a risk of overdiagnosis and overtreatment. Yes, genetic screening can lead to the detection of aggressive cancers, but overdiagnosis and overtreatment of indolent cancers might cause some harm. We know that some genetic conditions are indolent, meaning that they progress so slowly and they would not cause harm or death within the person's lifetime. So this could lead to overdiagnosis, and this diagnosis can lead to interventions and treatments and procedures which are not beneficial and may carry their own risks and side effects. Overdiagnosis and subsequent unnecessary interventions can increase healthcare costs. We have also some cultural and social barriers. There are cultural inhibitions around discussing prostate cancer and family history. There are fear of cancer diagnosis, lack of awareness about genetics, mistrust in the healthcare system due to the historical inequities, religious beliefs, social stigma associated with the genetic conditions, and impacts that all of this impact the test result interpretation and can hinder the engagement with the genetic risk services. For example, the cervical cancer screening, where cultural barriers significantly affected the participation in Africa. Women's low uptake is due to the cultural norms of modesty and privacy, requiring spousal approval, and religious beliefs discouraged exposing their bodies. Finally, we have to focus on foundational needs. You know that the current burden of prostate cancer in Africa is likely underestimated. Yes, it is underestimated due to significant challenges, including the lack of reliable cancer registries and screening facilities, limited access to healthcare, and inadequate allocation of health budgets for cancer care. A recent meta-analysis of the literature on prostate cancer incidence in Africa um, found that um, over the past 35 years, they only identified 40 studies that met the inclusion criteria for over 16 countries. The estimated full incidence rate across the study was 22 per 100,000, whereas the regional incidence rate varied dramatically. Now let us see what the other team advocated for and how can we respond. First, they said that catching cancer early could save lives. But as we said, there is a severe lack of genomic studies on the prostate cancer within the African population, meaning that the genetic risk factors are poorly understood from the first place. Current recommendations, as we know, for genetic screening are only based on data from the European and the African American population, not on the African genetic ancestry. Furthermore, global funding mechanisms often neglect the most vulnerable regions, including discrimination against indigenous population and gender inequalities, contributing to the overall health disparities across the continent. They said that genetic screening could be cost effective. However, according to one study, they calculated that the cost of the genetic screening, which was $60,000 for men with average risk. Another study found that the lifetime cost of prostate cancer screening and treatment could reach to $262,000 per year of life gained. They also argued that genetic screening could build genomic capacity, but we know that we have underfunding and resource scarcity, shortage of healthcare professionals, and inadequate facilities. So most African nations allocate insufficient GDP to the healthcare, leading to frequent shortages of medical supplies. We have lack of doctors, nurses, and overskilled personnel and we have many hospitals and clinics, especially in rural areas, that lack modern equipment and the necessary infrastructure to provide high quality care. So we have to focus first on the underfunding, the shortage of healthcare professionals, and the inadequate facilities in order to build a genomic capacity. Finally, they said that genomic screening could reduce health inequities. However, we know that we have to prioritize many other health inequities issues like poverty, education, ineffective healthcare infrastructure, and unequal distribution of healthcare workers first. To close up, many African countries have limited access to high throughput genomic technologies, bioinformatics expertise, and infrastructure, and funding necessary to conduct genomic studies and perform big data analytics. So, this lack of resources hampers efforts to generate robust data sets that capture the genetic diversity across the Africa's many ethno-linguistic groups. What do we recommend? First of all, collaboration between African and international researchers is essential to overcome the current limitations. Second, strengthening the healthcare infrastructure. And third, to promote PGS literacy. Thank you. Thank you for listening. Waiting for your thoughts on the debate platform.